One of the most common injuries that we see in athletes is an ACL tear. The ACL, as you can see in this model, is one of the main ligaments in the knee. It's right here in the middle and in the front and provides stability to the knee. Oftentimes when it's injured, it makes the knee unstable and the athlete's not able to perform at their highest level. Therefore, we would recommend surgery to help fix the ACL, and the surgery would be an ACL reconstruction, where we make a new ACL and that takes the place of the old ACL. There are different ways that you can reconstruct an ACL. The first distinction is between what's called autograft or allograft. Autograft means using the patient's own tissue to make a new ACL, and allograft means using cadaver tissue to make a new ACL. For patients that are older, the age of 35, for the older athlete, we would usually recommend the allograft or cadaver tissue to reconstruct the ACL. That's because in that age group, it's been shown that they have a quicker recovery, the complication rates are low, and the graft re-tear rates are low. However, in the younger athlete, younger than the age of 35, we would recommend what's called autograft, which is using the patient's own tissue, because it's been shown to have better outcomes and lower re-tear rates in the younger athlete. For that, we have several options that we can use to reconstruct that ACL. The first option is what's called the patellar tendon, which is one of the ligaments below the kneecap. The second option is the quadriceps tendon, which is a ligament or tendon above the kneecap. And then the third option is the hamstring tendon, which is a tendon that comes from the hamstring muscles behind the leg and wraps around to the front of the knee. My preference is to use the quadriceps tendon as the graft for the ACL, and that's because the quadriceps tendon graft has been shown to be a reliably thick and strong graft, has low re-tear rates, and has low complication rates, and many athletes are able to get back to the field or the court at a high level and back to their previous performance level. Some of the disadvantages of the other graft choices are for the patellar tendon graft, many times the graft length can be a different length than what the ACL should be. Many times, because you're making an incision in the front of the knee, patients will have residual frontal knee pain even after recovering from the surgery, and difficulty with kneeling on the knee. And then some of the disadvantages of the hamstring graft is that many times the hamstring tendons are going to be a small and narrow tendon that's not as thick and not as strong, and the hamstrings are actually in a normal knee help to stabilize a normal ACL, and so when you remove the hamstring tendon, it will theoretically destabilize an ACL.